our presentation is about a development and validation of the Geriatric Abdominal Surgery Predictive score that we call the GASP score. So this is the research team and the setting. So the study was conducted in Tanzania in Kilimanjaro Christian Medical Center. It was from July 2019 to 2023. And what is the main reason for what we have done the study is according to that critical problem in low-income country about the pre-op investigation. For example, when you want to operate on a geriatric patient, so basically imaging and labs are almost not present. Yeah, we have basically some kind, especially in villages, we have just the ultrasound, X-ray, and we can barely do just an HB. So there is no electrolytes, or those image labs are very are not present there. So intraoperative, for example, intraoperatively, we have the equipment are very poor. The equipment are very poor. And for postoperative care ICU, it's most of the time it's not well equipped, or sometimes it's even inexistent. So the clinical characteristics we are almost based on vitals and history of the patient when we are attending those patients. Vitals and history, yeah. And I present you an image of an operating theater in a village. You can see that operating table. This is the room, the operating room. And this is the lab. So just basic things, hemoglobin and maybe hematocrit. So things like those investigations like electrolytes are not, it's difficult, it's very difficult to do them. So just grouping and this is you can see the surgical operation done on a patient, a geriatric patient with intestinal obstruction. So despite the fact that we have not electrolytes, we don't know the potassium, we don't know 1, 2, 3, 4, but we are based on clinical characteristic, and the station are following about this. And that's why we say, what if we can work on a predictive score that can help us to attend those patients, to categorize them, and to do a better follow-up. Yeah, that was actually the problematic, or the thing that guide our research. So in the theory, so the aging population in Africa is now increasing because the life expectancy have also increased. And with that, we have elevated mortality. The perioperative mortality, for example, in Africa, just in Africa, is twice the global average. And there is some tool limitation. The existing tool like POSOM, ASOS, it's lack what we call the geriatric specificity, and also the low-income country feasibility. For example, with the POSOM, those sophisticated investigation, it's difficult to conduct them in villages and poor setting area. And the study objective was first to identify independent predictors of mortality. So to determine the key factor associated with 60-day mortality in geriatric abdominal surgery patient, to develop a GASP score, what we call the Geriatric Abdominal Surgery Predictive score, and to validate the performance. So we will assess the discrimination and calibration according to the triple guideline. The methodology, so it's a triple compliant design. So the study design was a retrospective analytical cohort study following a threefold guideline for predicting model development. And the sample size calculation, we use the Rile's formula for predicting studies, and we calculate our sample size to be 594. Inclusion criteria include more than 60 years, so 60 years and above patient undergoing abdominal surgery, and the patient who complete clinical with a complete clinical data available. Primary outcome was all cause 60-day postoperative mortality. Yeah. Now, the candidate predictor that was assessed, so we take the demographic, age, and sex. And for clinical data, we take the shock. The patient was on shock, for example, was classified. And tachypnea, if the patient had a tachypnea on admission. The Charlson index, we have used the Charlson comorbidity index to classify the patient according to severe comorbidity or not. And also the surgical characteristic, if it was an infectious diagnosis, for example, for patients with intra-abdominal sepsis. So we classify them as, so according to the nosology grouping, infectious or non-infectious process. And also if the surgery was emergent or not. Yeah. And the characteristic of the population, so we have, as I say, 594 total patients with a mean age of 68.4 and a deviation standard of 7. And the male patient was predominant with 59.9%. And we have 88 deaths, which is almost like 14.8 mortality rate. And this was within 60 days postoperatively. And when we did the bivariate analysis, so the shock was the main cause of the mortality, as we can see. So we have the shock, then the infectious disease, the ASA classification, if there was a peritoneal contamination, what we call an intra-abdominal sepsis, if the patient was, the surgery was emergent, so emergency also was linked to mortality, and tachypnea also. Now, those bivariate, those elements that was like statistically significant, we include it in a multivariate model, regression, logistic regression model. And 4 independent predictors was shown to be more linked to so we did a multi-Cox regression to identify those key mortality risk factors. And we found like 4 predictors. So the first one was a shock. The patient who present with a mean arterial pressure of less than 60 millimeter of mercury have a hazard ratio of 4.7 with a p-value of 0.001. And we take the coefficient, and this gives us an integral point of 2 in our predictive score. For the Charlson comorbidity index superior or equal to 3. So the patient who have moderate to severe comorbidity have 3.4 more risk of dying with a highly significant p-value. And for intra-abdominal sepsis, 4.0, and tachypnea also was, those 4 elements was found as predictor to mortality. And when we try to calculate the performance of our score, so for the model discrimination, so the area under the curve was of 0.72. That we found that it was an acceptable discriminative ability for clinical utility. And the score totally, all the score range from 0 to 5 points. And as you can see in the Kaplan-Meier survival curve, we can see that for a score of 0, the patient have almost 100% survival rate. But when we go we increase. So when the score increase, for example, for the score of 5, the mortality rate is 0%. And the difference between the risk strata was highly significant with a p-value less than 0.001. And then we have derived a risk stratification, and we have proposed some clinical action. For example, for low-risk patient, these are patients classified between 0 and 1 point. The mortality rate for them is 2.1 to 8.5% of mortality risk. And here is the standard care we are giving to patients. For intermediate risk, so the points are like 2.2 to 3 points. This is over 5, as we say. And the mortality here, it's 23.8 to 40%. Here, what we advise is first the comorbidity optimization before taking the patient, especially for patients who are like for elective patients, so we have not to rush and go operate on them. So comorbidity optimization is a good thing to do before thinking to go and operate on this patient. And for high risk patients, so we have 4 to 5 points. Here the mortality rate is 60 to 100%, as I show in the picture. So for 5 points is almost 100% mortality risk. And here the action is pre-operative, you book the ICU, and so ICU admission. So the you know that when I will be done with massage, I will shift the patient to ICU. So you contact the intensivist to prepare the after operation care of the patient, and also to discuss with the family the palliative focus. For example, to especially in a low-income country, where we can prioritize the resources instead of doing some future intervention. So we have to talk also with the family about the risk of near like 100% mortality risk if the patient has a risk of 5 points, a score of 5 points. Oh, about the clinical insight about, for example, the shock. So we know that shock emerged as the highest weighted predictor in our score. It was 2 points, and it's mainly due to age-related cardiac reserve that's decline and the resource limitation we have. Yeah, we sometimes we are in scarcity of crystalloid. We have the crystalloid fluid shortage, delay in vasopressor initiation, and we know all the physiology which is which involve the geriatric patient with the diminution of the beta adrenergic responsiveness and the baroreflex sensitivity also. So for the tachypnea, because the initial hazard risk was 133.5 at the baseline, but it's declined to 2.4 at 72 hours. So this specifically reflects how this pathophysiology evolved from metabolic acidosis to late complication. And for this, what we have asked, what we propose is to do a protocolized monitoring at 0, 6, 24 hour, and 72 hour, because the tachypnea itself was not really a predictor, but if it stay for more than 72 hours, then the patient became to decompensate, and this was calculated with a point of 1. So, which means that we have to monitor those patients and support them with some kind of oxygen or so to yeah. Now, we have tried to compare the GASP score we have developed with the existing risk score. For example, the GASP, we find that the low-income country applicability is very high because it relies solely on clinical parameter. And geriatric focus is yes, and the Key limitation, this will be the next step. We are now starting with the external validation of the GASP. We are working on that, so we'll start very soon. And for example, the POSUM, it's very low. In low-income countries, very difficult to apply it. Labs and imaging are sometimes very difficult to have. And for ASOS is very good. It's designed to African population, but it's lack the geriatric focus. And for the GES also is very low because labs, you have sophisticated tool that you have to use, albumin and whatever. Yeah. Okay. Now, what are we proposing? So we have talked about what we call a perioperative optimization strategies. So when we have a patient, we start by the shock management. So protocolized resuscitation bundle, rapid IV fluid administration, and early vasopressor initiation to restore the hemodynamic stability. Then we have the infection control. So time to antibody initiative should be very shortened. So empiric broad spectrum antimicrobial therapy. And then for respiratory support, incentive spirometry to reduce the postoperative atelectasis, and oxygen conservation strategy will help also to improve the outcome. Yeah. And about what we call the system level impact and implementation. So the resource triage benefit, this will help us to do a very good triage because we'll have low risk patient, moderate risk patient, and high risk patient. From there, we can easily do a triage and apply different bundles on different risk type of the patient. It will help us to conserve critical care resource for high-risk case, to optimize the bed allocation in resource-constrained setting, and to guide also the clinical decision support. Yeah. What was the limitation of our study? First is a single sample design, which required external validation, and we are trying to work on that. We will start very soon. So we are in a preparation phase of the external validation, which will be multicentric study across diverse African settings. So we are targeting like 7 countries for the second, for the external validation study. And there is also some unmeasured confounder like the frailty matrix, because the study was a retrospective. Sometimes it was very difficult to have those data like the frailty matrix. The nutritional status was also very difficult to have. And we think that in future study, if you integrate them, maybe it can help to improve the score itself. And the time dependency validation also. For example, the tachypnea decay model requires validation in a prospective real-time monitoring study. Yeah. And future direction, we have talked about it, the external validation. We will enhance the integration, and we are preparing also at the end of the validation, we will do an implementation research to know if the different measures we will be applying will help us to improve the survival rate of all those patients, despite if they are scoring 5 or 4 or 3 or 2. Yeah. Yeah. And as a conclusion, so we think that this score can help us to transform geriatric surgical care in low income countries. So the GAP score presents a paradigm shift in mortality risk stratification for geriatric abdominal surgery patients in resource limited setting. So it has a very good clinical impact because you have universally accessible parameter. Yeah. And the performance is very good. We have seen it with the calibration with the area under the curve of 0.72. So we have also, we can also easily do an implementation. So these are, we we give a special thank for this work. It was supported by COSECSA and Intuitive Foundation through a research grant. And we thank also the Kilimanjaro Christian Medical Center where we did the study. And we acknowledge that our research team for the dedication to data collection, and we are grateful for all the people who help us about this research. Thank you very much.